Good afternoon and welcome to Instituting a Security Program with Teeth, a complimentary webinar from healthsystemcio.com. Just some housekeeping before we begin. My name is Anthony Guerra. I'm the editor-in-chief of healthsystemcio.com, and I'll be your moderator today. We encourage you to ask questions. You can type them in at any time in the lower right-hand corner of your screen. In the Q&A box, leave the default set to all panelists, and we'll pose them to our speaker later in the program. You can download the deck. You have the URL in front of you, and I'll send it out in the chat box. And there's a shortened URL at the bottom of all the slides. And we are recording today's event, so we'll have an archive, and we'll put it on our YouTube channel as soon as possible, definitely within 2 business days, usually much sooner. You'll get an email when it's ready. Just so you see how we're going to spend our time today, we're going to go about 40 minutes. First, we're going to hear from Dennis LaRue, former SVP for IT Planning and CIO at Rockford Health System, and then we'll have our Q&A with Dennis. So without any further delay, I'm going to turn it over to our good friend Dennis LaRue. Dennis, thanks for joining us today.
Thank you. Good afternoon on the East Coast and good morning everywhere else. I'm pleased to be with you this morning, and I'd like to be able to describe to you our security oversight function, one that we believe has been successful in warding off possible incidents over the years. Of course, I knock on wood when I say stuff like that because we have to be good all the time, and incidents, bad things can happen only one time to a very significant detrimental effect. Let me begin by describing who we are. I do not have slides regarding who we are, but let me describe that. All of this information that you're about to see is developed and historically from Rockford Health System. Rockford Health System is comprised of a 396-bed hospital, about a 50,000 visit emergency department, about 140 physicians with 10 clinics, a visiting nurses association, and we're associated with a Health South Rehab Hospital also in the city. We have 10 clinic locations around Rockford and our main hospital campus here on North Rockland Avenue. In January of this year, we merged with an organization in Wisconsin called Mercy Janesville, and we are now Mercy Rockford Health System. And together, we're about $1 billion company. We have about 550 physicians, and we have 4 facilities, one in Janesville, one in Wadsworth, Wisconsin, another one in Harvard, Illinois, and the main hospital here at Rockford. But the IT groups have not yet been integrated, and Mercy Janesville, as the previous entity, had some kind of security oversight function as well, but I'm not speaking to that at all. I'm simply speaking to what we had at Rockford. So with that, I want to describe how you might instill a security program that has teeth. And of course, what we mean here is, how can you make the organization behave in a way that protects patient privacy and confidentiality? Some organizations may be able to do that more effectively than others. I think there's a lot of issues around culture that play into that, but this is what we have done at Rockford. So many years ago now, we instituted a security oversight committee. The committee is comprised of 6 individuals. The CIO is the chairman of that group. Also, we have the Chief Technology Officer and Chief Security Officer. That is a member of the group representing the IMS side, or the Information Management Services side. We had the Director of Risk Management, who works for our, she's kind of independent. She somewhat reports to legal, but is not really part of the legal team. but she is the individual that has to reply to to patient complaints and items of that nature. And we also had a senior HR consultant, very important to the group as we discuss what discipline we may need to prevent and discourage people from inappropriately using medical records and sharing information they should not, or at least obtaining that information. And finally, we had two individuals from our legal department. Our Vice President of Legal Affairs and General Counsel attended as well, and he also assigned the Corporate Compliance Privacy Officer to attend the meetings. So the team of 6, okay, is the group that would review and does review information regarding possible breaches in confidentiality and misuse of our medical record. So the committee meets monthly. We don't meet in the month of July, but we basically meet 11 times a year. Incidentally, the meeting today is the meeting for this month is actually starting in an hour. The first meeting was held all the way back to 2005, and in 2005, we did not have a viable electronic medical record. We had something called a clinical data repository that held patient information. It was an old homegrown type 1 CDR medical record. And obviously we had to pay attention to confidentiality there too, but not to the extent we do today with the EPIC platform that we have. So we have 10 years of history, and some of the cases that we'll talk about today and some of the things are most recent because we've had to increase the diligence, so we've added some tools to the process. And so most of the information that you'll see today relates to like the last 12 to 18 months of existence of this committee. Okay, so on a monthly basis, we publish a formal agenda. And this committee covers everything from patient privacy to web attacks, to denial of service attacks, to the newest information that we may have gleaned from different sources on what we should be concerned with overall security. You'll see 3 examples here. It's the month of July we don't meet. So you have June, May, and the August agenda. And you'll see things like email encryption requests. In some cases, for example, when we recruit new physicians, the physician recruiters in the organization will want to send information to them and receive information back. And we encrypt all those messages. And sometimes they want a dispensation on the encryption. And if they want to argue that they should have that, they come to this committee to do it. Another example might be when we discovered an Android security flaw that's brought to the committee and to at least discuss whether we believe it's material enough to make changes in any of the processes or security around the use of Android phones in the use by physicians. So this gives you a flavor for some of the things that we have done through this committee. So we'll pick the month of August agenda to proceed. And the reason I did that is we're going to hone in on basically one item on this agenda. So in the month of August, you see something called Fair Warning Report. And Fair Warning is actually a product that we used. I'm not trying to promote them in any way, but we do use that product. And much of the information we're going to see in a few moments is a result of the use of that product. Now, why do we have this product? With our EPIC platform for both ambulatory and hospital EMR. We literally run millions of clicks, okay, on the access of information. And it's physically impossible to troll through all the information that Epic can provide without either significant staff or some algorithm to identify what might be suspicious, if you will. I was just at an Epic meeting, the Epic user group meeting at the beginning of the month, and I went to a cybersecurity presentation and was kind of surprised in a way that many organizations, they don't just have a chief security officer, but many of them are staffing that chief security officer's office up with 3, 4, and 5 FTEs to monitor the use of their electronic medical record. We don't have that at Rockford. We didn't have that at Rockford, but this product allows us to do much with less and provides us a lot of information to focus on possible infringement on privacy. So some of the information that is provided through this tool, okay, relate to the following. We can show what would be a closed with incident. It basically is a category that the automatic audit, which goes through thousands, if not hundreds of thousands of clicks, shows a cause to open an investigation. It's basically a probability that something might be in disarray. Upon further review and manager input, it is determined that there is an infraction of RHS policy and or HIPAA policy. Corrective action is applied and recorded in automation. Documentation is forwarded to human resources for follow-up. There's different levels of corrective action. We'll get into that later. Closed without incident is another category. Audit shows cause to open an investigation. Upon further review and the manager input, it is determined that there was business-related access, acceptable access, and no incident or corrective action is enforced. So this would be the possibility that there was an infraction, but with investigation, a demonstration that it was a legitimate use or access. All investigation documentation is uploaded into automation and attached to the information. There's an automatic link between our Epic platform and this tool that that nobody has to intervene with, and the product produces reports particularly to that. Now, I must add right here that this documentation review is specific to the Epic EMR. There's other business infractions or that could be, I guess, perpetrated. For example, the passing of company information without encryption. It could be another incident, but this is focused mostly on patient records and not those other things. And this particular product does not cover that entire waterfront. It simply covers the EMR, okay? RHS is currently using automation to track HIPAA breaches and security incidents. And let me get to the next slide. There has only been one repeat offender since automation was fully implemented. And before that, before automation was implemented, we had approximately 9 repeat offenders. So we believe this automation, as we've advertised it through the company, has helped to deter the inappropriate use of medical records. And that's been a good thing. Okay, so this is just the latest information in terms of what this product or this audit tool has revealed. And I've got obviously May, June, July, and August. And here are some of the things that it found. We have what we call a coworker snooping report. somebody in the medical record looking at another employee's record. Obviously not good. We have a household member snooping report that somebody who has access to the record is actually looking at either their wife's record or their kid's record. Now, all this you can get through medical records, okay, in an appropriate way, but the use of the EMR simply to go trolling through those records is inappropriate. You know, my son who's 22, I can't even get his medical records, but if I have access to Epic and he came in for a lab test, okay, I could be caught snooping in his record. Okay, now that's illegal, so we don't want to do that. But this report shows that a possible household member was snooping at another individual's. Look at the green bar. Most of the incidents are employees looking at their neighbor's information. I don't know if that's a surprise to anybody, but that's not a good thing and is a very serious concern. So you can tell that by the green bar on these graphs. We have a policy internally where even though we believe the record is the patient's record, our employees cannot go into the system and look at their own record. And so that's what the self-exam report is all about. We also have a report that tests the VIPs. If we have a VIP in the building, we have a report that says how many people looked at their EMR summaries. The test is different than the VIP report. The VIP report is the one that I'm referring to here. So we have a number of alerts that provide us information about the types of snooping that could be going on, which leads to investigations. This graph is very an easy graph to look at, and let's look at the month of July. In July, we had 13 open and active investigations going on, we closed 7 of them that month, but these 7 could have related to the ones that were open in June. And we closed 1 that was closed without any kind of incident. We don't have that information in August because when we produced this graph, we had, for that part, eliminated all the open and active by then. So let me go on to the next slide. Of the investigations, we had 21 that were open and active against 18 that were closed and 32 closed without incident. So that's what 53 and 83, 81 particular investigations that were going on based on the information that was provided through this algorithm. Of those investigations, these were the types of things that we found. 103, a majority of the investigations were auto alerts of unauthorized access or disclosure. We had 37 that were unauthorized access or disclosure that were not auto alerted. And then we had a number of nickel and dimes here around, one was about theft, one was a phishing incident, one was an employee complaint, one was a password violation. And so this is our second quarter report that for us would have been March, April, May. April, May, June, and led to the following violations. After looking at those investigations, we found that there were 23 unauthorized disclosures. There were 47 auto-alerted disclosures. These 2 relate to system failure and have nothing to do with whether there was a relevant incident. So we found this number of violations relative to all those investigations that we had completed. And the 42 were closed, and we'll go right by that one. All right, so the current active automations, and I've reviewed them, were co-worker snooping, household member snooping, neighborhood snooping, self-examination snooping, and whether there was VIP snooping. So we have these reports that provide us information to go forward. In terms of closed with incident, we found that we had to educate, of all the ones that we did close, 55 of those incidents were closed with further education. The employee either claimed they didn't know it was a policy breach, or they said that they didn't know that the incident would be as severe, I guess, as that we thought it was. And so many of the incidents were closed with further education. 2 were closed with written counseling. 7 were closed with a warning, and 4 were closed with final written warning, the last step before being terminated if there are repeat offenders from there. So this graph shows how we've closed incidents. And this timing here is most recent, does not cover all the way back to the beginning of our committee, of course, but these are the things or the results of our closing incidents. The tool provides us a number of different things. I don't think I want to go through each one of these dials, but the dials represent places to go look at if they're found to be out of whack, if you will. But they also relate to specific HIPAA code. There's a HIPAA code 164.308, security management process. There's audit controls, security management, all the way through, and they each have a different flavor to them. And the product allows us to measure how we do against them. If you look at 164.402, risk assessment of breach, determine whether a risk assessment exists to determine significant harm or breach. This tool allows us to collect that information. Now, what do we do about stuff? When we, this is a document that we prepared for the organization, telling them that we were going to automate the way we monitor the use of the medical record and how we wanted to protect patient privacy. And I highlighted in yellow the things that I showed you earlier in terms of the results of some of the breach activity, family's record, own record, that kind of thing. And so we published this policy to the organization, telling them that we had the ability to look at all this information. And that's when, if you recall, I said that prior to the tool we had about 15, I think, possible breaches, but since the tool we had minimized the violations. So this document allowed the organization to understand that we were looking at their every activity and that they could be caught if they were in violation. So we published this, and then this relates to the specific policies that we have a number of IMS policies, of course, but these 4 policies relate to the items that we tried to educate the organization on that were important to the establishment of security around patient confidentiality. This is an example of one, information systems access and authorization policy, where managers have to approve each of their employees' access to our different systems. So this is requesting access. So we have very formal policy relating to that. I think I have another example, a security incident response. This particular policy relates to what we need to do if, in fact, we find a significant incident of inappropriate use of medical records. This is not necessarily leaving a laptop in the car that has your entire file of confidential patient information on it, but this is, it addresses some of those, but it's basically to tell the organization that there's some significant risk to security incidents, and these are the things that will need to be addressed, or how we would address them depending on whether or not it was a level 1 through level 4 infraction. A level 1 will not have a significant adverse effect, embarrassment, or penalty to RHS, its patients, or employees, all the way to a 4 where we'd have significant adverse events. We'd have to basically contact the newspaper, and we're trying to instill on the organization or every employee that we don't want to do that, obviously, and they don't want to be part of any infraction, if you will, that would cause us to have to do anything like that. Okay. Let me hesitate here for a moment. So one of the things that we find difficult in terms of a deterrence is that we have, in fact, disciplined various individuals for infractions. But legally, we don't make that very public. So it's not like we have a gallows in the parking lot and we say, this person violated patient security policy, patient information security policy, and this is the discipline we just laid on this person. So that obviously would serve as a different example or deterrence to everybody else. The problem with that is we're reluctant to make that very public. And so consequently, when we do discipline people, much of the organization doesn't know it, with the exception of some of the graphs that I showed you earlier. We can show you numbers, but people don't really know why. People don't know who. People don't know when. And so kind of lose the deterrent effect on those examples. But let me explain a couple of, I've got 2 case studies of situations that we found and what we did about it. And all this information, as we share it through the organization, is very generic. We don't identify, again, who. There was a point where I thought it would be beneficial to do that, but our legal counsel indicated that it might be doing more damage than good to actually identify some of those things very specifically. So, example case number 1. This is a 3rd shift nurse that had access to our EPIC records, and this person was identified repeatedly looking at neighbors' records. And what's interesting to me is when we confronted this individual the first time, and the person's confronted by HR, not by the CTO, not by the CIO, not by legally, they're confronted by HR, who has the information that we produce through these tools. And the first time we met with that person, she was surprised that we were able to identify that she had done something at a certain time and date. And you'd think that that would have been enough to stop her from doing that, I guess. But about 2 months later, we found another report with that same individual's name on it. And she was again doing neighbor snooping. And so she went to, we escalated, HR escalated to the point where it was a final written warning. And then that person did it again. Well, at that point, HR terminated this employee on the facts that were produced by the system. Again, not much of the organization knew that occurred, but that person did face termination for having violated our policy repeatedly. And when we talk about a program that has teeth, I think this kind of lends itself to what we believe is the type of program that has teeth. When you actually terminate a RN, even with a nursing shortage and things like that, that is showing that we're serious about the privacy of our patients and we're going to take action if people violate our policies without regard. The second item or case study that we have was a farm tech. Now, obviously, the pharmacy, all the pharmacists and farm techs have access to all patient records. And this individual had some lab work done and was anxious to see the results of the lab work. Now, what's interesting is that lab work also posts on my chart in our EPIC example. But this person actually used their office, their bench computer to access that laboratory work on themselves. And that's a violation of our internal policy. And so as we identified that incident, that person was counseled by our Human Resources Department and given education, reconfirmation of the policy itself, which said you can't do this, you can't access this stuff from your bench computer. If you wanted it, you can go to MyChart or go to medical records to get it, or wait for your physician to provide it, but we don't allow you to do this off the same tools that you use for all of the patients you serve as a farm tech. And so in this particular case study, the education was well received, and we've never had another incident with this individual since. So hopefully this served as a deterrence to this person. Now, I don't know whether or not this particular individual talks to their friends in the pharmacy and say, don't do this, because there may be some natural deterrence there, but we don't know that for sure. We don't know if the terminated RN in the first case study, we don't know if that person went to work for one of our competitors. We don't know if she went home and said, I got fired because I did this. So we don't know whether there's a natural deterrence there. But we believe that by the enforcement of our policies and our HR involvement, that we're teaching the organization that we're serious about all these things, and thus, again, hopefully our program has teeth. I think I've run out of slides, basically, and I'd be willing to entertain any questions or discussion you might want to have around these items. Anthony?
Excellent, Dennis. Thank you so much for that presentation. Now we have time for our Q&A. First question that's come in, Dennis, is to whom does the Director of Risk Management report? Is it the CEO, CFO, or someone else?
Risk Management reports to our COO, who is the Senior Vice President for Administrative Services and COO. She has a dotted line to legal, okay, but she reports to the COO for the house, for the system. Now that's the old organization. With the merger, we haven't gone so far as to restructure the entire organizational setup as of yet.
Okay, very good. You mentioned your Security Oversight Committee. Was there any debate when putting that together about who would be on, who would be off? Just talk about some considerations as folks out there are looking at the committee they have or considering putting one together. Who are the positions on the fringes that didn't make the cut, or maybe you think your committee was too big and you would have had a few less?
Did you mention physicians just now?
I did not.
No, physician. We knew that if we were going to build a function that would take discipline seriously, then we needed legal and HR, because before that, it was primarily the CIO office that was concerned about data security. I guess coming in from the other direction about, firewall breaches and things like that. But when we started reading all the HIPAA requirements and all the patient privacy and security requirements, I thought that we'd never really have agreement. I, for example, could not discipline any employee on my own. I would have had to involve HR to do that. So we thought the committee should have representation from HR and legal and compliance. So was there any argument up front in terms of who would be represented? I don't recall that. And we could have expanded the whole thing. We could have had the CNE there. We could have had the CMO there. But we thought that HR, legal, and IT would be appropriate to carry the ball, and we didn't include anybody else. I'm not sure, Anthony, if I've answered your question.
You did. You did, and you answered it well. Intentional versus unintentional offenses, you take those things into consideration, and I guess at some point unintentional gets a little old as far as an excuse, but are those things you try and figure out during an investigation?
Yeah, if it's a first offender, and that's why there was on the blue graph it said 55, I think it was 55 were resolved by education. First offenders often walk into, well, I didn't know we couldn't do that type of thing. And so HR, we kind of educate. But if that name shows up in a subsequent report, a second time, then we'll say, well, wait a minute, we just educated you, didn't we? What don't you understand about this? So it's the second incident, I guess, that would cause us most concern. But we try to at least educate on the first incident, and so far we've been able to do this pretty regularly. The volume, even though we're a pretty large place, what was it? It was like no more than 70 or 80 incidences that we had to cover. So that seemed to work pretty well, and so far it has. And we're seeing the number of incidences actually drop. So I think the education is beginning to work and permeate through the organization in a good way.
Okay, very good. It's interesting to me that you continue to do the manual audits to sort of check on how the automation was working. Is that something you definitely recommend? And if so, how long would you recommend continuing the manual audit process? Well,
we found that product at an Epic UGM. It was associated with the Epic EMR, and we didn't know how well it worked, and we wanted to make sure that the information it provided didn't give us a number of false positives. So we often tried to discipline people for wrong reasons. And so we monitored the product for about 6 months, and we started weaning our way from the manual audit and relying a lot on the reports that it generates.
Very good. Does the tool that you're using integrate with any of your other security tools? And if so, do you have a single pane of glass view of overall security and compliance?
We don't have a single. Well, we have a SharePoint dashboard that we've created on our own that highlights how many hits from China did we have today against our firewall and things like that. But they're a little bit different than the focus on the patient privacy side. And so we kind of rely on this product mostly for that because our entire EMR is now integrated for both ambulatory and in the hospital. We do have a VNA that's still on a different application, and this product doesn't dig into whether or not a VNA nurse is violating any policy. And it's difficult. That's probably an exposure because it's difficult other than a manual monitoring of their activity to see whether or not there might be a violation. So, but this product specifically focuses on our Epic platform, and we do have a dashboard for other things. But I think the focus here is on the patient privacy side, and that's why we're emphasizing these things.
This is a final question. How long did it take you to stand up your tool, and how many team members managed or directly administered it?
It took about 60 to 90 days. In a kind of we had a formal project plan, and the people that needed to be involved were in networking and in our programming group to make sure that that EPIC was providing the tool with a stream of data that it needed in a correct way. So when I say 30 to 90 days, that also included a testing period. So it didn't take that long to get it going. And again, I know that we're trying to stay away from product promotions, but the product works pretty well in our opinion.
All right. Well, that's a great Q&A and a great presentation. I think extremely valuable information. It's about all we had time for today. So I want to thank our featured speaker, Dennis LaRue. As I mentioned, you'll receive an email when our archive has been posted to our YouTube channel. If you have the CHIME CIO certification, let CHIME know you attended our event today. Attending our webinars gets you one CEU, and if you've asked us to let CHIME know, we will. Sponsorship opportunities, contact Nancy Wilcox. Questions and comments, you can reach out to me, and you can go to our website to view our upcoming schedule. So once again, I want to thank our good friend Dennis LaRue for joining us and providing this great information, and everybody have a wonderful day.